Thank you for the kind introduction, Wes. Good evening and welcome everyone. The topic is mainly on management of urinary incontinence from the primary healthcare perspective. Urinary incontinence is a very big topic and it's a bit tight to have it covered within 45 minutes. And basically tonight I will focus mainly on management of stress incontinence and urge incontinence particularly. And also important before we go into those management, is crucial to understand the pathophysiology of each of the urinary incontinence before we can accurately tailor the management specific to the condition. And also what I would like to do is to have a brief explanation on how to assess the patient from the primary healthcare setting. Certainly I wouldn't do the advanced kind of assessment as in urogynae setting, but it's also important to know the basic investigation that can be carried out in the primary healthcare setting. Also understanding the principles and roles of conservative and medical therapy before we send the patients for further assessment at the tertiary level. And then if we have more time, we can probably touch a bit more on the more advanced management option of urinary incontinence. Prevalence, worldwide prevalence is pretty much consistent around the world. It's been reported around 16 to 30%, and mainly with the stress incontinence effect in particularly younger age of women after the childbirth in the 30s or mid 40s. And overactive bladder tends to affect approximately 12 to 70% of the women, and 1 in 3 will have both of the problem at the same time. It's really interesting. Urinary incontinence is a problem that people don't like to talk about because they feel embarrassed to talk about it. And it's interesting to know that most women, you'll be surprised to know that they don't know that there's anything can be done to make them feel better. It is not a life-threatening condition, but it is a condition that can significantly affect their quality of life. All we can do is to just screen them by asking them whether you have any bothersome symptoms or bothersome leakage. Would you like to do anything? It's just simple as that. It's like opportunity screening questions you can ask them. This diagram it's adopted from one of the American study. As you can see, 1 in 3 have problems and they don't seek for help. It's partly because they don't know there's anything can be done and they're too embarrassed to talk about and they're too worried to ask around until like 10, 20 years down the track, and then they realize that, oh, by the way, it can be done, it can be fixed. And only 1 in 10 has seek for help. What about the risks associated with urinary incontinence? As I said earlier on, it's not a life-threatening condition, but eventually all this, with the prolonged urinary incontinence, they can eventually lead to some form of long-term health issues. Not a direct health issues, but indirectly. Specifically in the elderly woman, there's a double risk of nursing home placement for that group of people, increased risk of depression, increased risk of fall, and in the younger group of patients, they do complain of sexual dysfunction. You'd be surprised to see women complain of coital incontinence, orgasmic incontinence, which is interfering with the intercourse. We see lots of them in our clinic setting. What about in Australia? Again, this is pretty much consistent with the data around the world. This is adopted from one of the Australian Institute of Health and Welfare data, as you can see that. In terms of definition, again, most of the conditions are self-explanatory. As you can see, urge incontinence is usually preceded by urgency before they cause the involuntary leakage. As opposed to stress incontinence, again, is an involuntary leakage associated with exertion, particularly with coughing, sneezing, or any form of strenuous activity. And then there's the mixed symptoms, which is a combination of both. This is a very interesting group of people. Again, 1/3 of the patients will have this sort of problems. And what we're trying to ascertain is usually we try to find out which one is more of a problem for the patient. Is it the stress part or is it the urge part? Because we generally try to treat the most bothersome problem, and majority will have an urge predominant issue which can be dealt with. And I use this diagram usually try to explain to my patient on various type of incontinence. This is a very simple cartoon diagram and easy to understand. Overflow is like patients not aware of the sensation, or they have no sensation to void and eventually get overfill and have a leakage. Stress, again, is self-explanatory. Women do describe leakage when they try to carry their baby or lift their child, coughing, sneezing, laughing. Urge incontinence, as you can see, trying to rush to the toilet and have leakage before they manage to get to toilet. And the functional is, again, is multifactorial, as you can see. It's either due to mobility issue that they can't get to toilet in time, or they have other issues like the cognitive issues, delirium, dementia, and etc. And then there are a less common form of incontinence, which is the congenital, as listed there. Fistula, again, is not uncommon to see, particularly after as a form of obstetric complications from cesarean section or any form of operative delivery. And that's one of the major contribution. Gynae surgery, particularly associated with hysterectomy, that's another common cause from gynecological perspective. Functional, as I alluded on the previous slide, delirium, infection, atrophy, and then that's a diapers pneumonic, as we're all aware of. Before we talk about management of incontinence, I think it's extremely important to understand how do we achieve continence in a normal individual, and it's multifactorial, as you can see. It's depending on a neural control, either central or peripherally, and then we have the neuromuscular level, i.e. the bladder detrusor muscles, and the myofascial supportive structure, i.e. the supportive ligaments and the fascia of the vagina. And specific to stress incontinence, as you can see, the continence is achieved by the balance of the intravesical pressure, the balance of intravesical pressure against the urethral pressure. So the urethral pressure has to be higher than the intravesical pressure to maintain the continence, and that can be achieved by coaptation, meaning it's a soft tissue closure of the urethra to stop the leakage, plus the muscle tone, plus the supportive structures around. There are various theories people have been talking about the incontinence for particularly stress incontinence. What I'm talking about here, it's the pressure transmission. So if you have disruption of any of the supportive structure, as in the urethra being mobile or hypermobility, and obviously the intra-abdominal pressure would have exceeded the urethral pressure and hence causing leakage. The other theory is the sphincter deficiency, where this is a classic description. People use the word drain pipe urethra, if you've heard of that term. It's a rigid, open urethra, which can be treated in a different manner. And certainly it doesn't take a lot for the patient to leak, and usually they say by getting up or walking, they start leaking. And then the other famous theory is the Hammock theory, which is well described by one of the American urogynecologists. Is like pretty much the fascia of the vagina acts like a hammock to support the bladder and the urethra, and obviously childbirth would have disrupted this supportive structure on the anterior vaginal wall and causing a drop of the bladder neck and the urethra, and hence causing leakage. Risk factors, again, it's always multifactorial. It's not one or the other. There are some risk factors that are not modifiable, particularly female, and the very certain the European are more likely to predispose to urinary incontinence. And of course, if they have familial or collagen tissue disease, they're more likely to have that. We can't change that. Things that we can change is the obesity and the other comorbidities, smoking, menopause, and etc., etc. Childbirth and hysterectomy, those are the two big condition. That's one of the biggest risk factors that contributes to urinary incontinence. So from primary healthcare setting, how do we identify this group of people and how do we address them once you identify, and what do you do? So as I mentioned earlier on, it's very, very simple. It's like you ask them a simple question, and then if they say yes, so a positive screening test, and then you do a detailed clinical and examination assessment, including investigations like MSU to make sure that that's not a UTI, which is quite common. It can mimic urinary incontinence. And then you treat whatever is reversible, like the mnemonics that we talked about earlier on. If they still have incontinence, by doing this basic assessment and management, and then you look into more specific condition. Is this a stress component? Is this an urge component? Is it a mixture, or is it something else? Or is it something abnormal in the anatomy side of things that's contributing to the leakage? Certainly, at any stage, if you have any concern, those patients will warrant a tertiary referral to the urogynaecology. And clinical assessment, again, I wouldn't go too much in detail. Again, this is pretty much ascertaining what type of incontinence, if they have overactive bladder, nocturia urgency, frequency, and urge incontinence. Sensory, whether it's increased or absent, that is pointing towards some form of neurological disorders, or if a patient who is in a postpartum had urinary retention, they have overdistension of the bladder injury, they couldn't feel that, or if they have some form of regional anesthesia that contributes to that. And certainly incontinence, as I mentioned earlier on, there's various types of incontinence where you can ascertain from the history. Dysuria, hematuria, bladder pain, all those things are red flags for us to expedite the referrals to tertiary centers, because that might indicate some form of malignancy or foreign body or any underlying serious pathology that can contribute to the symptoms. Quality of life is extremely important. This is something that people tend to overlook when we assess the patient, and basically that will give us an idea how fast we should intervene. Previous treatment is extremely important, particularly if they have overactive bladder symptoms and had a previous surgery. Then we know that people will assume that it is a new onset of overactive bladder, but it could be a complication